We're going to describe our approach to cystinuria. The philosophy is looking at the whole patient rather than just the surgical aspects, which is what urologists generally focus on. So we'll be talking about medical care of the patients, but also a holistic approach to how they manage a lifelong disease.
So cystinuria is a very rare form of kidney stones. The exact incidence is not known, but it's thought to vary between 1 in 2,000, maybe 1 in 15,000, and that varies per country. So for a patient who presents with a first-time stone, often the diagnosis is difficult, and that actually can lead to a delay in diagnosis. In our series, the average delay to diagnosis can be as much as 7 years and before people realise. And that's because the stone isn't sent off for analysis and people aren't really thinking of that.
Cystine occurs when there's a defect in the transport protein in the proximal tubule of the kidney. The transport protein is composed of 2 subunits which are encoded for by 2 genes, which we'll talk about in a moment. If either of the subunits is faulty, then cystine can't be reabsorbed into the blood and there's an accumulation in the urine. This causes a problem clinically because cystine is not soluble in the quantities that are then in the urine, and that's how patients form stones. The same transporter mechanism also transports 3 other amino acids, ornithine, lysine and arginine, but they are soluble in the quantities in the urine and therefore they don't pose a problem clinically.
The inheritance pattern of these 2 genes is interesting, as SLC3A1 is inherited as an autosomal recessive manner, whilst SAC7A9 can manifest as an autosomal dominant fashion, and hence this is referred to as autosomal dominant with incomplete penetrance. The diagnosis of cystinuria is made on stone analysis or elevated urine levels. Genetics are not required for diagnosis and at present are more of a research tool. The problem for caring with these patients is that they are often looked after by different specialists and have recurrent stones and pain in a working age population with young families. This fragmented care and difficulty obtaining the orphan drugs that they require can lead to frustration amongst the patient group, who often then become labelled as difficult and non-compliant. So we're going to show you a video of a complex cystine stone. This is a 25-year-old gentleman who had cystinuria since the age of 10. He had a history of 3 PCNLs and had been unable to tolerate medical therapy and had previously taken potassium citrate and tiopronin. He was then referred to our unit for management of this stone. For those eagle-eyed amongst you, you will have also spotted that there was a stone in the right ureter, and this was treated ureteroscopically beforehand. Whilst you can see from the CT scan that it is a complex stone, I think this 3D reconstruction just shows how complex that stone is, and trying to render this patient entirely stone-free is not at all straightforward. So we decided to undertake a combined ECIRS approach using a single lower pole puncture. After clearing the bulk of the stone with ultrasonic lithotripsy via the percutaneous access, we then pass a flexible ureteroscope into the calyces that we could not reach. And as you can see in this video, this is now just being passed into a posterior calyx with the laser fibre. The operator is then able to enter deep into that calyx and laser the stone. And what this actually does, it brings stone fragments back out into the renal pelvis, which we're then able to extract, and also gives us access with the ultrasonic lithotripter, allowing the bigger fragment to be more efficiently cleared and then removed.
This is the typical appearance of the cystine stone, which tend to be homogeneous, crystalline yellow in appearance, and as you can see, we're taking advantage of the fact that cystine stones are so hard that they rarely vaporise as well as other stones, and we're therefore creating larger fragments which can then be removed. We're able to continue lasering deeper into that calyx, and further large fragments are brought into the field of view. Here we're using the flexible ureteroscope and a basket to remove stone fragments from that calyx, and then with what's called a pass the parcel manoeuvre, we're passing the basket and ureteroscope down into the nephroscope to allow removal of this large fragment. With this approach, we've been able to render the patient virtually stone-free with only minimal trauma to his kidney.
Lithotripsy can be used, although in general these stones are thought to be harder and therefore more resistant to lithotripsy, but it can still be tried, and some patients it does work well. We tend to try and prefer ureteroscopy instead of PCNL, just due to the recurrent nature of the stones that they experience, and therefore they have multiple procedures throughout their lifetime. They may well need less stenting as their ureters are often more dilated due to the frequent passage of stones, but when they do need stenting, it's important to note that their stents may encrust very quickly, and this image shown here is a stent that's been in place for just 7 days, and you can start to see the crystals forming on the stent already.
Once we've cleared the stone from the surgery, then we'll see them in the clinic. In 2008, we established a multidisciplinary clinic where patients could be reviewed and investigated in one visit. They're offered joint consults with a urologist and nephrologist. They have same-day imaging with CT, ultrasound and X-ray all available. And they have a variety of urine investigations including pH, amino acids and urine cytology. They also have access to a dietitian, which is a unique feature of our clinic. We've also done some novel things regarding diet, including recipe books and cookery classes.
The uptake of the dietitian review has been excellent, and patients really value this unique service. The results have been good, with 58% increasing the amount of fluid that they drink, 72% increasing the fruit and vegetables, which leads to a rise in the pH. And of the obese subset of our population, 35% of those patients have lost weight through our dietitian service. Patients have significantly reduced their animal protein and correspondingly increased their vegetable protein, and there's been a 68% reduction in salt intake.
Despite fluids, dietary changes and alkalinisation, some patients will still need to go onto a thiol drug or chelating agent. These are tiopronin and penicillamine. They work by reducing the disulfide bond in the cystine and forming a cystine molecule. These drugs definitely work in reducing stone episodes, but they come at a high price with many side effects, and patients need to have regular monitoring with blood and urine tests if they are taking these medications. Other aspects of our service include pharmacy support for the orphan drugs, a specialist nurse that patients can contact directly if they have issues, and we make sure they come in for any surgery as quickly as possible, and they're offered their surgery within 2 weeks.
Because of the rare nature of the disease, our patients find difficulty accessing information. We therefore created a patient-orientated website which covers all aspects of the disease, from diagnosis to treatment.
So there are lots of different aspects to managing a patient with cystinuria, not just the surgical treatment of the stones.
Engaging with those patients to help themselves, but also to give them access to medications, and also easy access back into the hospital to see us when needed is important.